Thank you, Kirsten. Um, Thanks everyone for the invitation. It's really an honor to be here with you today and to be able to present a little bit on the national registries for intensive care units and how they actually responded to the pandemic and worked in terms of surveillance that aids preparedness and brings us some information on the epidemiology, but also new knowledge translated into research. So I'm an intensivist. I'm also a co-founder of EpiMed, a member of the BRICNet, the Brazilian Research Intensive Care Network, and a researcher at the Door Institute, as already mentioned. Um, so there are several challenges that actually came suddenly into our daily tasks and daily battles in the ICU with the pandemic. This figure here from a recent article which I participated in, published in Intensive Care, it kind of depicts a little bit of the several challenges in terms of caring for the critically ill patients, organization, systems approach to all this critical care crisis, staffing pool uh, challenges, related challenges, supply challenges. So many things came into the scenario 14 months ago when the pandemic started. And it was very sudden and it didn't give us much time to organize and respond to it. So we had to learn as the pandemic developed. But if I had to summarize here what's pertinent to my presentation in terms of all those challenges and how the national ICU registries responded, I would say that ensuring bed availability, understanding what are the usual COVID outcomes, and therefore being able to provide some measure of what's happening to these patients and how my ICU is performing and am I being efficient in terms of caring for these patients, but also producing scientific evidence to advance outcomes. I think that summarizes a little bit of uh, regarding the many challenges that ICUs had, what national registries for ICUs did. So national registries are, in general, networks of hospitals that are based in a region or a country that capture clinical information and translate this information into case mix outcomes and efficiency metrics that helps to track and improve quality of care, such as is the MICA project in Belgium. What I'm going to present you today is not an overview of what all the registries did, even though we are doing research on this area, but rather a focus on what we learned from this and what happened using information from the national registries in Brazil, where I'm based. So first of all, why local and regional surveillance matters. So this slide here is from a paper that we did using EpiMed data from public hospitals in Rio de Janeiro 3 years ago. And what we saw when we were looking at community-acquired pneumonia patients is that delays in ICU admissions increased twofold the risk of hospital mortality in ICU patients. And it was one of the main individual and independent predictors of mortality of these patients that were related to organizational issues and not only to clinical issues for these patients. Of course, we can think that it clearly translates to what we are seeing now, still seeing with the COVID patients. So how did surveillance act in terms of improving preparedness and fast tracking the access of the patients to intensive care units? So what I'm going to show you here is what we did with EpiMed. So when we started with the pandemic, we faced the challenge of the pandemic. The first thing that we did was let's try to reconfigure the diagnostic setting and include the diagnosis of COVID in our data set so that we could have both the suspected cases, the confirmed cases, and the clinical cases of COVID, and then at least starting to track, being able to internally track for each ICU, but also as networks, what was the burden of COVID and the outcomes of these patients. This happened very quickly, 3 to 4 weeks after the beginning of the pandemic, it was already online. And then the second thing that we tried to do was to actually have a broader vision of what was happening. So as we already tracked with EpiMed, just like you guys do in Belgium with the MICA project, the current occupancy rates, the near real-time information for resource use, such as the use of mechanical ventilation, the use of ECMO, the several different uses. What we also tried to provide here was actually what was the landscape for my ICU. So we provided this sort of monitor here, which was derived from EpiMed data, combining diagnosis of both severe acute respiratory infections and suspected and confirmed COVID cases with all the clinical and case mix data that we had on EpiMed. Also, we also added a part on structure and capacity, where the hospitals could enter their own supplies of conventional ventilators, other ventilators, potentially recruitable beds, so that it could be easily understood what was the pool of ICU beds and the pool of resources that could be moved in case a surge of ICU severe patients with COVID came to the unit. So here what we're seeing is near real-time information of this intensive care unit, the current hospital admissions, current adult and pediatric ICU admissions, what was correspondent to COVID, what it represented in terms of near real-time occupancy rates, but also use of other resources such as ECMO, mechanical ventilation, and a little bit on hospital outcomes. This helped ICUs locally to monitor what was happening within a single ICU or within a hospital with multiple intensive care units. But also, it's very hard for us to try to act in a pandemic without the proper context. And by this, I mean that maybe you're doing all this good monitoring in your ICU, but if you do not know what's happening around you in terms of the dynamics of the pandemic and the number of and the burden of severe cases, then you cannot anticipate how it's going to impact your ICU tomorrow or the next week. So we also provided, using benchmark, what was happening in terms of trends over time. What was the number in a given region? So here it could be the country like I'm showing, but it could be regional, or it could be even a hospital network working with just what was happening among their own hospitals, trying to be able to track what was happening, predict what was going to happen, and then allocate patients according to not only local availability, but an understanding of what was going on within the region. So here we could see total hospital admissions in red if they increased since the last day. The same for ICU admissions of COVID patients. Here is the cumulative rates for these that I mentioned here before. And here's, so here it was SARI patients, here is just for COVID patients. And here what we're seeing is cumulative data on hospital survivors and non-survivors and those remaining in the hospital. So it gave us a really good perspective in terms of caseloads, but also an interesting broader perspective, that being complementary visions on local ICU management, hospital management, network management, and regional, national level epidemiologic information. This translated into potentially good management of the surge. So here is a paper that our group published a couple of weeks ago on intensive care medicine, showing an integrated hospital network, 45 private hospitals in Brazil, located in 6 different states, 126 ICUs. And what we saw here was data from EpiMed showing the number of patients in the ICU through the first wave from March to August. And here we're looking at what actually happened in terms of new admissions to the ICUs, ICU deaths, and ICU mortality rates. But one interesting information here, which is not directly on the slides, is that this hospital network managed their supply of critical care beds and ventilators by using the previously shown dashboard. And what they did was that 2 or 3 times a day, they checked and they made meetings where they could share information on local availability and therefore be able to reference patients to other hospitals if they were already saturated or close to being saturated. And they presented actually pretty good results and were able, even in the peak of patients, to accommodate most patients in a timely fashion into an ICU bed. The second thing that national registries can provide us is benchmarking. So understanding how good our results actually are in terms of the outcomes of patients. And we know that COVID-19 really made a mess of our baseline structure organization and even knowledge on case mix and outcomes. So this happened for several reasons. Some of them are here and we summarized in the 2 recent papers, one in intensive care and critical care, that exceptionally high number of cases of higher than usual severity of illness patients, coupled with potentially reduced staff because of burnouts, because of sick leaves, or because we increase the pool of ICU beds without necessarily increasing the number of staff for the same beds, and also full hospitals that resulted in strain and reduced bed availability would potentially lower our adherence to evidence-based practices and then increase complications, increase also worse outcomes, morbidity, mortality, and lengths of stay of these patients. So in brief, when COVID came, our perspective on what is my usual length of stay, what's my usual mortality rate, and even what's my usual standardized mortality rate was a little bit lost because the sudden change in the case mix really represented a new challenge into understanding this. And it's became clear very quickly when some epidemiologic studies that the COVID patients are sicker than the usual ICU patients, that their mortality rate seems to be higher than the usual ICU patient, even the usual mechanically ventilated ICU patients. Their lengths of stay would be 30 to 50% longer in the ICU as compared to the usual mechanically ventilated patient for a several number of reasons, including a protracted disease course in the ICU, sicker patients, strained ICUs, and also that they kind of messed up with our understanding of the case mix and the standardized mortality rates for a number of reasons that we are not going into detail here. But anyway, if we are able to provide information from a national registry, local information, national information on benchmarking, as you see here on this template, which is from epimedmonitor.com, you are able actually to look into what's going on and compare your own results with the results in your region. And then you're able actually to try to better understand what's actually happening in your ICU and what is happening to the outcomes of these patients. I'm going very quickly through data on 150,000 ICU admissions for COVID in the EpiMed Brazilian database from the beginning of the pandemic until last month. And here, just to understand how it shifted from the usual, we saw that actually, although the severity based on the SAPS-3 scores increased a little bit, what actually increased was the rate of mechanically ventilated, the duration of mechanical ventilation. So here, for instance, as compared to our baseline data, which is around 17% of mechanically ventilated patients, 50% of the COVID patients are ventilated. When they come to the ICU, invasive ventilation, 35% non-invasive, and 56% of the patients remain in the ICU longer than 7 days ventilated. This changes a lot our results, but as we are able to look into this data, we're able to compare our own results and understand better if we are performing well or how far from this curve we are behaving in terms of effectiveness of care of our patients. The same happened into lengths of stay, of course. So this patient stay very long. The typical COVID patient stays for 3 weeks in the hospital. And when we compare to usual clinical medical patients that came to the ICU, this number used to be something around 12 days. So that's a big change in terms of resource use in the ICU, but also straining the ICU because these patients stay longer in the hospital and it's hard to get them out of the ICU. So this data here is mostly to show that by looking at the benchmarking, we can try to better understand our results and also find targets for improvement, even in a situation just like COVID, where it's a very new situation and a new case mix, and we may be feel a little bit lost in terms of how well or how bad we are doing in terms of caring for these patients and its ultimate outcomes and results. Finally, the last part of my talk. I will talk a little bit about research using the EpiMed database. So there's been several papers published during the pandemic using this structured database that were either local publications, that meaning a single ICU that extracted its data and analyzed, or ICUs that joined and were able to collaborate because they shared a structured database that could be easily merged for research. So I'm going to show you just a little bit of some examples of things that we did during the research here. Just examples from 2 papers and how we believe they added value in terms of bringing new knowledge into the pandemic and its aspects. So this paper just submitted is a paper that where we used the same hospital network, 45 hospitals, 126 ICUs that have been using EpiMed for a decade. And we looked at 514,000 ICU admissions over this 10 years period in this integrated hospital network. What we were aiming here was to try to understand what the pandemic affected and how the pandemic affected the secular trends in terms of lengths of stay, case mix, and outcomes of the patients. And not only because of COVID patients, but also what happened to non-COVID patients. So the first thing, and very briefly here, is that we see that although there was a continuous improvement in terms of crude mortality rates, there was a worsening, expected worsening of mortality, crude mortality last year. And even a reduction in non-COVID admissions, of course. But we also saw that this mortality rate had a similar pattern for non-COVID patients. So even when we extracted COVID patients from the analysis, the same results were there, showing that the pandemic affected the level and quality of care and the outcomes of non-COVID patients. What we also could see was that there was a clear correlation between the mortality of non-COVID patients and COVID admissions. That being said, this is a Vlad analysis, so it looks inversely. So that's when it goes down, it means that unexpected mortality is going up. So what we see here is that as the pandemic started, this is week 1 of the pandemic, there was a quite good trend. But then in the 8th, 9th week of the pandemic, there was a sudden shift that represented increase in the mortality, just as the number of cases of COVID increased. So non-COVID patients died more than expected when increased COVID admissions happened. And then it started to improve, number of cases going down. And then when it went up again, the number of mortality also went up again. So that's, I think, proof that we can use this type of information for improving and increasing the knowledge and finding quality of care gaps that can be translated into potential actions to improve outcomes. Finalizing my presentation here, so we also showed in a recent published paper the survival trends over the periods and showing that there was actually a learning curve, that risk-adjusted mortality decreased over time when we looked at the periods, comparing period 1 and the last periods of the pandemic in this 14-month trend, but also that some aspects such as increasing use of non-invasive ventilation when we compare the first period and the other periods were associated with survival. And actually that non-invasive respiratory support, something that was not used so much in the beginning of the pandemic, was strongly associated with increased survival of ICU patients. So this was a general idea of how national registries can help actually in the pandemic, using information to not only propose local management of ICU beds, national management of ICU beds, understanding and identifying actionable indicators for quality improvement, and how it can be also a solid base of clinical research to increase the knowledge on COVID-19. Thank you.